I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Hi everyone, and welcome to the December 2018 edition of the PRS Journal Club podcast. My name is Francesco Egro, PRS Resident Ambassador from the University of Pittsburgh Medical Center, and as always I'm joined by my co-resident ambassadors Ira Savetsky from NYU and Nicole Phillips from the Harvard Plastic Surgery Program. I would like to take the opportunity of thanking them for an amazing year together. I really couldn't have hoped for a better crew to work with and really look forward to working with them in the future. I would like to thank Dr. Rorick for the unique opportunity of joining the editorial board as resident ambassador. It has been truly incredible experience. I would also like to thank the whole of the PRS Journal team for their support and amazing work throughout the year. Today we have the great honor of being joined by Dr. Justine C as our guest moderator. Dr. Lee is the Bernard G. Sarnat Endowed Chair for Craniofacial Biology and Associate Professor at the UCLA Division of Plastic and Reconstructive Surgery. Thank you so much, Dr. Lee, for joining us for this PRS Journal Club podcast.
Thank you for having me.
Before we dive into our discussion, I want to remind everyone that this article, along all of the articles that are discussed on our podcast, can be read for free on prsjournal.com. The article we will be discussing today is by the UC San Diego group and it's entitled Distraction Osteogenesis for Unicoronal Craniosynostosis, Rotational Flap Technique and Case Series. I selected this article because since Jesse Taylor's discussion 35 years ago, there have been no ideal solutions or perfect solutions to this challenging problem. You still end up with asymmetry in more than 3/4 of patients, and 40% will require an additional procedure. So when I read this very clever solution to a dilemma that craniofacial surgeons have, I thought that it would be of great interest to discuss in our podcast, especially with Dr. Lee. So the authors conducted a retrospective review of non-syndromic unicoronal craniosynostosis patients who underwent anterior cranial vault remodeling with the author's rotation flap technique between August 2013 and December 2016. As a review, the technique consisted of first performing a limited osteotomy of the frontal orbital bandeau on the synostotic side to the lateral orbital roof of the non-synostotic side. Then hinged the rotational advancement of the intact lateral orbital wall pedicle on the non-synostotic side. Then the frontal bone flap was left in situ but designed and osteotomized as a rotational flap with the frontal bone being left attached to the underlying dura. Then a titanium cranial distractor was attached to the posterior bandeau and to the frontal bone flap in the planned vector of advancement. Finally, the distractor arm was placed through the scalp and the coronal incision closed over a drain. The distraction was then initiated during the postoperative inpatient stay and continued until overcorrection, and the remainder of the device stayed in place for 3 to 4 months to allow for bone consolidation. The authors operated on 16 patients with this technique and with a median age of 9.1 months and a median distraction length of 4 millimeters intraoperatively. The distractors were advanced a median of 27 millimeters and achieved a cranial volume change of approximately 25%. The median operating time was 171 minutes, and looking at complications, they were predominantly related to infections at the distractor site in 5 patients and broken distractors arms in 3 patients. All patients had a Whittaker grade 1 result at a mean follow-up of 5 months following distractor removal. I thought this was a truly fantastic paper, which I read with great pleasure, and I commend the authors for providing a truly innovative and clever solution to the challenging management of unilateral craniosynostosis. I feel the authors have demonstrated the proof of concept with this paper. Of course, long-term outcomes are needed, but I feel the authors showed that their technique can be a safe and effective method of achieving satisfactory aesthetic outcomes and volume expansion for these patients. But the challenging thing about distraction osteogenesis, I think, is the prolonged period of distraction, the fact that the vector is only posterior to anterior or transverse. However, the great thing is that you distract soft tissue as well, and therefore you're less likely to prevent cranial growth or to lead to recoil. One challenge with this technique, I thought, is perhaps to determine what vector to distract in. And the other thing is the hallmark of unilateral craniosynostosis deformity is ipsilateral frontal brow protrusion, but also temporal hollowing. And the long-term follow-up photo of one of the patient's forehead looks good, but she still has marked temporal hollowing, which I think it would be difficult to prevent with distraction osteogenesis. However, based on the published results, it looks like this technique produces a nice shape to the forehead that may last at least 4 years. But time will tell how it looks when they are teenagers. But if they could maintain a symmetric forehead, then the temporal hollowing could potentially just be treated with structural fat grafting rather than a cranioplasty. Dr. Lee, I'm curious in hearing your thoughts on this rotational flap technique described in this paper and also about how you manage unicoronal craniosynostosis.
It's a very excellent idea by Dr. Gosman and her group. This is a very interesting way of using distraction for unicoronal craniosynostosis and certainly adds to the armamentarium of the different techniques that we could use to treat the condition. Now, in terms of what do I typically do, I do a very standard frontal orbital advancement. In non-syndromic unicoronal craniosynostosis especially, this is a relatively straightforward procedure for craniofacial surgeons. It typically takes about 3-ish hours, which is pretty on par with the amount of time that it takes to do the distraction. And these days they're pretty safe. And yes, there are times in which a reoperation is necessary, but they're typically not as frequent as 40%.
Interesting. I must say, here in Pittsburgh, we also do FOA, and Dr. Goldstein is our attending that does them. And I mean, they're fantastic cases. It's just very interesting how, I guess, different surgeons have different preferences, and perhaps it has to do with where they train, not only during residency, but also during fellowship. What did you think, Nikki, about the paper?
You've already touched on one of my main questions, which was, I was sort of wondering about the high rate of deformity relapse and how that actually plays out. So it's interesting to hear different thoughts from different experiences. The other question I had reading through the paper was infection was the most frequent complication that they reported. And so I'm wondering, Dr. Lee, do you think the risks of infection potentially mitigate the benefits of this technique, or would you have any other additional suggestions in terms of prophylaxis or anything else?
Well, it sounds to me that the authors were able to address the issues of infection with increasing the types of wound dressings that they were doing and the sterility in dressing the distractor arm. Now, I think if the infection is a large issue going forward, then yes, that would not be acceptable because frontal orbital advancement in infants, the likelihood of infection is so extraordinarily low. But that said, we've been doing distractors in the craniofacial skeleton for various areas of the craniofacial skeleton for a long time. And the likelihood of having the distractor arms get infected, it's there, but it's not super high. I think the larger question, as the authors alluded to, is that techniques such as distraction and techniques such as using springs, you have to take them out at some point in time. So is it really worth the anesthetic risk when you could do this in one stage?
Yeah, absolutely. Thank you for highlighting that. Ira, what were your thoughts on this paper?
I thought this was a really interesting paper, and I agree with everything that was already stated in this discussion. Similar here, I've done a fair number of these cases with our craniofacial surgeons here, and a lot of them are, Dr. Staffenberg, a disciple of Kawamoto, also does the same approach as you, Dr. Lee. But I was just curious, distraction osteogenesis has been reported in other forms of craniosynostosis. Are there different forms of craniosynostosis that you think that there may be a better role for distraction osteogenesis rather than this one that we're discussing, the unicoronal?
As we know in the syndromic kids, distraction osteogenesis has been key, including posterior cranial vault distraction has been an excellent use of distraction. Transitioning from traditional advancement of a monoblock to monoblock distraction has greatly reduced the likelihood of infection and CSF leak. So those are great indications for distraction because just advancing alone doesn't seem to give you as good results as if you were to distract it, specifically for the monoblock. I think in this case, with non-syndromic unicoronal craniosynostosis, it's more of an addition of what else could you do? And as a surgeon, if this is the technique that you prefer and this is the technique in which you get the greatest results, then by all means, it's just like people who use springs. They love springs, and that's okay. So they can use springs and get great results from that.
Thank you all so much for a truly thrilling discussion, and thanks, Dr. Lee. We're very lucky to be able to discuss this paper with you. I really enjoyed today's podcast, and I think with that, we'll end our discussion of this article. Thank you everyone for joining us. If you like this podcast, please feel free to share with your friends and rate us in the iTunes store. Also remember to tune in to the other 2 articles we'll be discussing on this month's podcast. And finally, please join us this month for our monthly journal club on Facebook, where we'll be able to interact directly with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not yet done so already, and it is there where our monthly journal club takes place. Once again, Dr. Lee, it was an honor having you on our podcast today. Thank you so much for joining us.
Thanks for having me.